Let's talk about stillbirth. Definition of stillbirth is greater than 20 weeks or weight greater than 350 grams. Frequency 6 out of 1,000. After 28 weeks is 3 out of 1,000. Risk factors: blacks is 2 times, nulliparous and multiparous, which is prior 3 or more prior births. Less than 15 years old has 3 times risk, or greater than 35 years old. Male infant has a 10% risk. Obesity 5 times. Smoking 10 cigarettes per day 1.5 times. Multiple gestation 2.5 times. Prior stillbirth 4 times. Hypertension 3 times. Infections such as parvovirus, cytomegalo, listeria, syphilis, pregestational diabetes or gestational diabetes. If A1C is less than 7%, the risk is reduced. SLE, APS 4 times. Inherited thrombophilia is not a risk of stillbirth. Renal disease, IVF 2 times. 41 weeks 2 times. 42 weeks 5 times. IUGR 1.5% risk of stillbirth at 10%, 2.5% risk at 5 percentile. Potential causes: placental abruption is 10% of all stillbirths. Abnormal karyotype is about 15% of stillbirth. Other causes: infection, umbilical cord abnormalities. So abnormal karyotype is 15% of stillbirth. Trisomy 21 is about 30%. Monosomy X is 20%. Trisomy 18 is 20%. Trisomy 13 is 10%. So trisomy 21, monosomy X, and trisomy 18, and then trisomy 13. Amniocentesis is better for tissue sampling for karyotype. Microarray is better than conventional karyotyping. 20% stillbirth will have a dysmorphic features. Infection is about 20% of stillbirth. Could be from ascending infections such as GBS or E. coli, or from hematologic spread, listeria, RPR. Serology for toxo, rubella, CMV, HSV is not indicated. Huh. So check for listeria and RPR then. Umbilical cord abnormalities is about 10% of stillbirth. Nuchal cord not associated with fetal deaths. 25% of births will have a single nuchal cord. 5% will have a multiple nuchal cord. So a quarter of the babies have a nuchal cord. Vasoprevia, cord entrapment, evidence of occlusion of fetal hypoxia, prolapse, or strictures with thrombi. So infection is 20%, abnormal karyotype is 15%, placental abruption is 10%, and umbilical cord abnormalities about 10%. Nuchal cord is not associated with fetal death. Stillbirth evaluation exam of placenta, most important component of the evaluation by a trained pathologist. Look at placenta, look at the core, look at the fetal membrane. Placental insertion site 1 by 1 centimeter or 1.5 centimeter of umbilical cord can be used for cytogenetics. Examination of the fetus. Could do a fetal autopsy. Foot length can be used for gestational age. Patella or costochondral junction is placed in lactate ringer for microarray analysis. Maternal evaluation, we'll get a CBC, KB test, RPR, APS test, TSH, severe IUGR or family history is not done routinely. Oh, if they have severe IGR or family's history, then you get factor 5, prothrombin, antithrombin 3, MTHFR, protein C, and protein S. These are not done routinely, only if they have severe IUGR or family history. If the fetus was greater than 24 or less than 28 weeks, we usually can do either DNE or induction. DNE only able to hold the fetus after induction takes longer time. Risk of requiring a DNC after the remove a placenta. Can use misoprostol even with history of C-section. 400 to 600 microgram every 3 to 6 hours. Vaginally before 28 weeks. Can consider mifepristone 200 milligrams 24 hours prior to induction. Less than 400 micrograms should be used if prior hysterotomy. Greater than 28 weeks, we can use Pitocin. Subsequent pregnancies, increased risk for stillbirth 2.5% if prior stillbirth versus 0.5% in someone who had a live birth. Start NSC testing 32 weeks or 2 weeks before the prior stillbirth age. Kick count education, not shown to decrease stillbirth but increase intervention. Ultrasound to rule out FGR at 28 weeks. Induction at 39 weeks, or early term if patient is very anxious and accepts the risk of early term delivery. Let's just take a look at any of these things just in case I missed something. Tables. Okay, so this is the estimated rate of stillbirth for all pregnancies, about 6 out of 10. GDMA is 10 out of 1,000. With insulin, 35 out of 1,000. Chronic hypertension, 25. Preeclampsia, without severe features, 50 with severe features. What? It's actually lower. 30. That makes sense. FGR is about 50. Twins, 10 out of 100, 10 out of 1,000. Triplets, 30. Oligo, 15. Greater than 41 weeks, up to 40. Prior stillbirth, 20. SRE, 150. Renal disease, 200. Cholestasis of pregnancy, 30. Advanced maternal age after 40 years old is 20. Blacks, 15. Maternal age less than 20 is about 15. IVF is about 10. BMI greater than 30 is about 20. Smoking greater than 10 cigarettes is about 15. Let's see. Analysis of the stillbirth. We inspect the fetus and the placenta, weight, head circumference, length of the fetus, weight of the placenta, photographs of the fetus and the placenta. Obtain consent to have the placental block 1 by 1 or 1.5 centimeter of the umbilical cord. Internal fetal tissue specimen, either costochondral junction or patella. For autopsy, if there's no consent, it's just gonna be a visual inspection. Let's see. Stillbirth, if there's no clinical clues, we do genetic testing, APS, the KB test. If there is FGR or hypertensive disorder, we do genetic testing, APS, KB test. Suspected fetal anomalies, do genetic testing. Intrapartum stillbirth, APS, KB test, and other tests. Preterm labor, chorial, preterm PPROM, based on clinical suspicion. Do fetal autopsy for all patients, placental pathology for all patients. Elements of stillbirth evaluation, family history, developmental delays, consanguinity, VTE, maternal history, OB history, So subsequent pregnancies in the first trimester, we'll get a dating ultrasound, first trimester screen, support and reassurance. Second trimester fetal ultrasound. Third trimester ultrasound. Delivery, where you talked about. That's it.